the accident, some will happen. So we also need to improve the quality of care for those patients who will sustain injury. So in the pre-injury, these are more of, we need to understand the behavioral of the drivers, the environment, economic determinants, why this injury happened. I think we all are aware that during attending the trauma patient, we'll just ask the mechanism. But what happened during the accident, we don't know. Without knowing that and come to with good policy on how to elevate that, will not be able to reduce the numbers. So where do we stand? For example, in our setting, a lot has been invested in treating the patient and rehabilitation. But how that is effective in reducing the trauma burden, I think you have the answers. Do we have a national goal on targeting on road traffic accident or any injury? We don't have. But there are a lot of, for example, malaria, we know we have targets, HIV, we have targets, but when you come to trauma, nothing is there. So I think it's our time now to work. We come with good proposals, we do studies, at least we can have goals. We want to reduce trauma by what percent, by what time. So in injury prevention, the first thing is we need to define the problem. So knowing the numbers is not sufficient. We need to know why those numbers are there. What dynamics make those numbers big. So we have identified the risk, we define the problem, and then we come with the implementation plan and evaluation. And also we have to see what will be the challenges to implement what we are trying to do. So these are projects which we need to be done, and I think they are all doable. So where to intervene so that we can reduce the burden. So the pre-injury phase and the post-injury. So in the pre-injury phase, we need to study factors which increase the chance of accident occurrence and need to be researched. Also to identify risk factors, also measures to improve the quality of care to all trauma patients. And in WHO, they stated that if all trauma patients, they receive timely emergency care, we can save about 2 million lives in 1 year. So this is the existing gap. We don't have raw data which can give us the injury events, no set goals, pre-hospital care not well established in our country. But also the hospital care, we know the challenges which we are facing. So it's our call now to come with studies and projects to address these things. So these are not accidents, they are injuries because they are preventable. So there is a theory which is called risk homeostasis theory. So this was the study which was done in Sweden. They tried to understand why drivers they are involved in risk behaviors. So they have like 4 theories. The first one was trying to reward particular safe behavior of drivers, rewarding drivers who have not crashed, and punishing particular unsafe behaviors and punishing drivers for having crashed. So what they found is that those who receive punishment, they did not do well the next time. Because if it's issue of fine, they can pay the fine and they can move on with the risk driving behaviors. But those drivers who were rewarded on particular safe behaviors, they did well. So sometimes the fines which are being given by the traffics is not a measure to prevent the reoccurrence of the accident. So come to my topic of trauma registry. So this is a disease-specific collection composed of files of uniform data elements that describe the injury event, demographics, pre-hospital information, diagnosis, care, and outcome of treatment. It's an electronic file, which can be shared among hospitals. So we can be able to extract data from all over the country if we have this trauma registry. So these are some of the information which can be obtained. And there is WHO guideline for the trauma registry, but does not necessitate that the WHO guideline should be like in Tanzania. So we can develop our own. For example, Rwanda, they have their own. Uganda, they have their own. Why not us? So these are the questions we need to ask ourselves. Do we need to have our own? Who will pioneer the project? So that was about the pre-injury. So the post-injury, we have to improve the quality of service. So a systematic approach to every injured person ensure that life-saving intervention are performed and that no life-threatening condition are missed. And we all know that if we miss, for example, pelvic injury with retroperitoneal bleeding, the patient will die of hemorrhage. We can miss a tension pneumo. I think we all know the consequences. So the WHO developed a trauma care checklist. So it has two parts. So these are the things which you need to be cleared before the patient is being disposed to the final disposition. So for example, if the tension pneumothorax or the chest drain placed, you have to tick yes or no. So it's a good tool. And before team leave the patient, as the patient be given the necessary treatment, which serial investigation are needed, and plan of care is it to discuss the patient, family, relatives, other specialties. So all this will help to improve the quality of care to our patient and reduce the mortality. Thank you very much.
The final talk before we break for comments, clarifications.
Good morning again. My apology that I have to stand in front of you again in 10 minutes. This is not my talk. I'm presenting on behalf of Dr. Joseph Mwanga, who could not make it here because of the issues which he's facing. And he was thinking of presenting the orthopedic training in Tanzania and kind of say, where are we? The room is full, yes, thanks. But is that where we stop, or we need to go further with training? And if we have to do that, what training? So he's trying to like take us back to where we started. And especially the good example is these guys at this table, where if we ask one after another, how did they go through their orthopedic training, then you see what Dr. Joseph is telling us, that we had kind of a slow pace of orthopedic training in 90s, where those who are trained in orthopedics, either they did it outside the country or they had to go like 2 steps before becoming an orthopod. They had to do general surgery and then at a certain point find another sandwich elsewhere to become an orthopedic surgeon. But as time went, mid-90s, things kind of changed, that we had some local training. So I'm not sure with where did it start, the orthopedic training. These gurus, they'll tell us at a certain point, maybe during Q&A, whether we started at Muhimbili or it was KSMC which started training orthopod, I'm not sure. But yes, the training was like, okay, you were required to become a general surgeon and then orthopedics. If there were few who were interested to undertake that process, and the training really didn't match our needs. We needed more orthopods, but we had few because of the interest. And this is the question when the MED came in, which it started with University of Dar es Salaam, but then when it was the Muhimbili, we know now it was MOOCs, and then KSMC, but the same, we had very few candidates. You agree, majority of you, for instance, in my class we were 2, and I know some previous class there were only 1 candidate. Slowly, things changed. That after MUHAS, then KSMC had MED program, and then later on Bugando. Now we see the intake. Our first year there are 22, second year 17, and third year 15. So the number is big. I think the same interest we are seeing is growing in KSMC, where the numbers who says we are discussing on this chapter. We said this, that you had to go through the general surgery, and at a certain point, if you feel like you're interested to do orthopedics, yes, you have to do that. And majority of this orthopod were trained either in mission hospitals or some at Muhimbili. My apologies, looks like some slides are repeating. I think the main issue here was fine, after being orthopedic surgeon, are you interested to go for any further training? And if at all, there's that training super specialization in orthopedics, what are these specializations? Do we agree with both that, yes, spine is part of orthopedics, or is what we call trauma, is dealing with long bone fractures enough to say that a traumatologist super specialized in orthopedics or pediatric orthopedics or joint replacement, foot and ankle, hand, all these? I think at a certain point, MCT did ask us to feel what kind of specialty do we want to be in orthopedics. That after general orthopedics, then what will be the next stage? And in this sense, where do you train after that? You finish at MUHAS, and is the universities are the one who are responsible to train somebody into the super specialization we're talking, or that should be left to the hospital, and the hospital should train through the fellowship? And if at all, which fellowship in Tanzania are we ready to train? Which hospital are ready to okay, fine, I'm in Kinga and I have 3 spine surgeons, so I can take maybe 5 orthopedic surgeons who want to become spine surgeon and be recognized. I think that was kind of stimulant to this discussion. And you could still go outside Tanzania to get that training. Now, if that's the case, do we know the numbers? Okay, who are arthroplasty surgeons in Tanzania? How many? Where are they? And who are the arthroscopy or sport medicine, for instance? And can they do something to like train somebody else? And others say when you talk about trauma, then you should be talking about somebody who is able to do pelvis and acetabular plus the periarticular injuries. But how many do we have? And spine as well. As we said, up to this time, most of fellows whom we have here, they are trained either through CCOT or AO or COSEXA or somewhere else. And the question is the same, whether can we use our facilities to like train this fellow, and could that impact be obvious if we take that way? And this was said in the morning about the super specialization in our hospital. We know when you're talking about super specialization, we'll be talking about Moi, maybe Aga Khan, Bugando, KCMC, and that's it. But what about a regional hospital? Are they ready to have like pediatric orthopedic surgery, for instance, or a sport medicine? But the situation the way it is, as I said, most of these guys that are in Dar es Salaam and Mwanza, and I think Arusha is taking over. And our expectation is that Moi, Mlonganzira, Benjamin Mkapa, Aga Khan should start, taking part. But most of our fellows who we know trained maybe in India or in Egypt, yes, majority at Moi, few at Mlonganzira, Benjamin Mkapa, and Peramiho. They have. I hope I know, Luquinho, you are in Astute at a certain point. Can we have that now, the ongoing fellowship? We have pediatrics, orthopedic surgery ongoing at Moi, and trauma. There are people who come to train at Moi, get a fellowship in trauma, but they are all from outside Tanzania. Nobody has a trust that they can train at Moi and become a trauma surgeon to that specialization. And what are the challenges that we don't like to take over the fellowship program? Is it that who should join, and can the facility support you, or will like our facilities are not keen enough to like support somebody? And if you become, for instance, your general orthopod, your scale is here, but when you become spine surgeon, do they change your scale so that there's a different in your enumeration, or you remain the same? And could that be a reason why you are not, moving into this super specialization? Things that today it was said in front of a guest of honor by our president and positively taken, and perhaps that will increase our interest toward super specialization in orthopedics. So the way forward, the institute should support fellows. Whenever somebody decides to take a fellowship, they should be supported. Like you go to Egypt, for instance, or India, or you decide to like move to a different hospital within the country to train for a fellowship. And then the facilities should support super specialization services. When you get a spine surgeon at your institute, then he should be supported, make sure that he starts practicing that spine surgery rather than leaving him again going for hands and wash program. And I think that goes to NHF, that does those issues of private-public schemes to like absorb all these changes which we expect, that you have a super specialization in any of orthopedic part. Could NHF, for instance, recognize you, and when you manage patient, and reward you like that? And we should again focus on an area of a need rather than going for some issues which are not important. Thank you so much.
And Dr. Zlimo for your talk, and it's more of a research introducing research in orthopedics. As Professor Haonga started by asking in this room, how many have published in the past, did you say 10 years? And there are hardly a handful. So it means despite us being close to 100 orthosurgeons, but we are very much clinicians but then we have to move to the next direction of research. And Dr. Lim also took us through establishing a trauma registry. And the final talk, which was delivered on behalf of Dr. Mwanga, Professor Mwanga also was discussing the milestone of orthopedic training in Tanzania. And at this time, I also like to remind us that we are live in YouTube. There are some doctors and other people following us live in YouTube. And the correction was, there's a comment from YouTube that the MED orthopedics started in 2001 at the then MOOCs, now MUHAS. It started when the university was still under University of Dar es Salaam. So the first batch, I think it was the cohort of Anthony, Dr. Swaye. Swaye then followed the Anthony Luponda and the company. So I welcome the floor for discussion, comments, clarification from the from the audience and also from Dr. Limo and Professor Onga. Karibuni. Dr. Onga, can you step forward and a mic will be moving around the audience. You need only to raise your hand. Those following us from YouTube can also comment. You'll also share your concern by in this conference. For the three talks, comments, questions, more clarification. Karibu Dr. Mboya here in front.
Thank you all presenters for good presentation. My question is topic concerning Dr. Haonga about research. I do not know, or I wonder whether you consider, one may consider also the socio-economic factors first of the country at the national level and patients themselves, because I think if we are talking of prevention, then pre-hospital, at the pre-hospital stage, one may be more effective in the sense that the kind of roads we are having and the impact on trauma compared to the roads in our counterparts or developed counterparts. And also another issue of socioeconomic factor is our patients. They are probably easily lost in the follow-up because they may not be able to return to the hospital for follow-up and so forth. But more concern is at national level, where because our country is per capita, little per capita or poor per capita income may fail to look probably into this. Though I'm not trying to be more probably something to look into. Thank you.
Can we take one more concern? Pale kwa Dr. Nungu.
Mine is not a concern, it's a comment. Yeah. Yes, Dr. Rimo talked about the need for a trauma registry. I think this I really recommend TOA at this stage to come up with such a thing, because there have been attempts before to do that within our country, but it couldn't take off because these were not based group based like this one. Therefore, I think now the right time, and this is one of the reasons why we started this organization, or we started the TOA for such a things. Thank you for that, and I really appreciate that TOA is taking up this. We need it. We need trauma registry. And when it comes to specialist training, I can see a problem, because as the director talked this morning, the recognition of super specialists, yes, there is a need, and the government or the ministry recognizes. But we have a very big problem with the regulatory body and the licensing body. We worked for COSEXA for years to get it recognized. Still, they are stomping on that. Meanwhile, the specialists being trained in this country, had it not been for COSEXA, you wouldn't have pediatric orthopedics. And pediatric orthopedics is faring very well right now, and they're all recognized. I can see now with this platform and with what he said, through such a this pathway can help us recognize associations like ours, and colleges, so that people can be recognized. You can't. It's difficult to recognize someone who was trained in Egypt if you don't recognize where he was trained, because he will never come into the system. He will never be recognized by the employers. So I think there is there is work to be done, so that these associations and the colleges be recognized first, so that the fellowships can be recognized. Thank you very much.
Dr. Fire, and baada ya hapa I'll allow one more hand, then we go to the presenters to respond.
I would like to comment on the issue of people not doing research. After settling in, people not feeling very comfortable to pursue further studies. In general, people do research once you have satisfied the three basic requirements, life requirements. You got a housing, you got clothing, you got food, you'll do research. A hungry man doesn't do research. Okay, so this is why some of us are busy trying to satisfy the basic needs rather than doing research. And this will be there. It will persist until such a time when people come to realize that you must satisfy the doctor's three basic requirements. Otherwise, research is something we'll just be discussing at meetings like this. It also follows that if you want a doctor to come for further studies, you got to satisfy his three basic requirements. Otherwise, he will not move. If you wait for too long, Dr. Fire grows lots and lots of roots in Arusha, and you want to dislocate me to go and do super specialization, I won't go. Unless you compensate me in a certain way with a good package. I was listening to Banakondo here when he said, we have a good package for people who go to study abroad. I hope it is a package that will cover the basic requirements, because otherwise to get people to go out is also another issue. So much of what Professor Honga is saying is needed. We certainly need the statistics. But who's going to do those statistics? If you are busy chasing money to feed your family, I want them to look at that issue as well. Whether it is an institutional element or it's a government element, whatever it is, we need to satisfy people before we can start expecting certain function.
Okay, now can you give the mic to the presenters to respond, and we move to the next.
Thank you very much for the comments and questions. So I'll try to comment on Dr. Mboya's comment on the cause of pre-injury. The big problem we are facing as a country is we don't have data. We don't have data of cost of preventing vis-a-vis cost of treating a trauma patient. So reallocation of budget, I think, can be done basing on the data. For example, after came with the projects and doing the research, knowing that the cost of treating, for example, patient is this much, but the cost of preventing is this much. I think for a wise man will reallocate where the money to go. Thank you very much.
Yeah, I think there were many comments than questions, so I will just also comment on some. Yes, in Tanzania we have a big problem with recognition of training outside the medical schools. We are like tuned that to train a medical doctor should be done within a medical school, and the same as training a specialist should be done by the medical schools. But in other countries, different. Yes, medical schools does the undergraduate issues, but when it comes to specialization, then that is done by the college. We have a lot of issues within the system to identify a training without building. I think that's how COSEX is defined by the government people, that there are no specific building and there's no specific leadership of that college, that whenever a candidate has a complaint, then it will pin that Dr. Fire, you are the vice chancellor of this program, and here there's a problem. What should we do? Dr. Nungu brought in the pediatric orthopedics. I think the pediatric orthopedics, which was done under COSEXA, could have been done very well under fellowship, under the institution, if that was recognized, because it was an assistant guy from Canada who came at Moy, and he trained those guys at Moy, and those guys, they're at Moy now training other people. So if Moy has been awarded that power of conducting fellowship, that would be very easy. You are a fellow in pediatric orthopedics done under Moy. You are a fellow in arthroplast done under KSMC, and your certificate to be labeled that and to be recognized. That should be very straightforward. And we are the one to make those decisions, but we're still dragging our feet. Dr. Fire said very well that research, yes, you need to have some remuneration. And people do research for several purposes, remuneration being one of them. There are those who know good funders of research, and they write grants and send their grants to those funders, and they get a lot of money. I know people who have 5 programs, and each program pays them $5,000 per month. They're well than we who run from one hospital to another. But you need to have that interest to, like, okay, engage in research. I know I've been involved in research for the past 12 years. I had no pay. Only last year I got a study which pays me $500 per month. It's peanut compared to one joint which Mboya does, and he gets like 1 million. But it's a step. When I get 2, it's just an example. But if I get 2 or 3, I'll be fulfilling several of my thirst. One is, something I like do. Second, I have an extra pay instead of moving from Aga Khan to TMJ and again back to Moy. I might cut one of my clinics and concentrate on research. So there are money in research as well, good one. So it depends if you know those who are funding and hit their target to get the money.
Thank you all for presenters, Professor Onga and Dr. Limo. We'll now move to the next session. So we were to proceed with the next phase of our scientific presentations. You can see on the brochure, but we will now break a bit on a different type of presentation from one of our very main sponsors of this meeting, the Aristo Planet Farmer. So I welcome you, Dr. Bandukwala. Karibu sana. The podium is yours. He's a well-traveled speaker about pain management in different countries, continents, and we are very much delighted to have him here. And he shares his experience. The first complaint for patients in orthopedics is pain, and now guide us how to address this pain. Karibu sana.
Thank you very much, sir. Before I really start the presentation today, I just want to show you a 45-second video. Just a 45-second video. I'm sure it will work. Especially the sound will come. Amazing view of the mountain as a backdrop, and you can just see the whole lush green light of our sports. I don't know what it is because I have just got up in the morning. Hey, so wishing you all of you good morning. Hey, and a great day today and a good night and all my friends everywhere. Thank you. Bye. Thank you very much for inviting me here, sir, and giving me a platform to speak to all of you. I know I am a physician, maybe 40 years of practice all over the place, and I'm attached to Hiranandani Hospital and Lilavati Hospital in Bombay City, and probably are closely associated with Aristo Pharmaceutical for nearly 40 plus years. So I have probably an experience of both the sides of the table, sitting as a clinician and primarily and probably associated with pharma for basic information which comes in it. So makes me very, very current and makes me very, very interesting over a period of time. I'm in managing new molecules which come into the India, and basically using it in my practice is for the benefit of the patient. So when I'm speaking to all of you, such an august body, such a learned body, such expert surgeons here, I feel like an ectopic, you know. I wonder what an ectopic must be feeling when the ectopic is outside. I'm feeling like an ectopic here, but I'm sure, you will find a great time with me here for 15 to 20 minutes. It's on a different subject. Today, though the focus is probably on to a molecule which is known as butyrophenol. Basically, I want to make this presentation more clinical oriented and make it primarily for your benefit for pain management. And I understand that butyrophenol basically is tried to use in anesthesia as a part of controlling pain, but at the same time, what about postoperative pain management? What about pain management in other than anesthesia? What about pain management in biliary colic? What about the pain management in urinary colic? What are the molecules which we can use, which we are using now? If I take an example of India, basically we use IV NSAID like diclofenac sodium. But when we order IV diclofenac, we feel that the patient may probably have have a renal problem, especially patient is elderly and dehydrated. And if we try to use fentanyl or if we try to use pethidine, we are worried that patient, and especially in surgical scenarios, we don't want to use pethidine and morphine for abdominal pain because it will mask the signs. So we are all worried that not only the patient will have respiratory depression or patient will go into a narcosis, but patient will mask the signs also. So we are basically looking for a molecule which be as good as a narcotic, but have no potential side effects in terms of respiratory depression or masking of surgical signs. And I was really surprised when I was reading this particular on this particular molecule. I found that in terms of post-operative pain management, rather it is orthopedic, surgery, neuro, or whatever it is, that in 90%, the recent paper showed that 90% of patients are unhappy with their post-operative management. And I was talking with Dr. Sheikh. I was talking with Dr. Sheikh during the break now. Thank you. I think you do. I was talking to him and he said that once the surgery is over, the anesthetic disappears. We depend so much on the anesthetist is to take care of the postoperative status of the patient, but he basically disappears, and we are left on our own to ask our registrars and housemen what painkiller to use. And simply we primarily use either a paracetamol or we use a tramadol, or probably in a very scenarios we can use fentanyl. We don't use fentanyl at all in the postoperative control. Once the patient is out of the theater, we don't use at all. So we were always looking for a non-narcotic molecule which is an opioid but not narcotics. In terms of the best pain management, the pain molecule is opioids, and it has come through the ages. If you go back in time from Egypt onward, the first molecule which was used was poppy seeds and popium, and that was also a part of over the century. Is the opium not only led to an addiction, it led to wars and everything else because it led to narcosis and addiction. But today also the opioids basically remain. Next slide. Opioids basically remain as a principal pain in a restrictive pain, in a very severe pain management. If we can't manage pain with anything else, we would like to manage pain with an opioid, risking the whole thing. So to quickly go through a classification, when we talk in opioids which are available to us, we have various receptors available, and they act on the various receptors. These are known as mu receptors, morphine receptors, kappa receptors, and accordingly they are classified as whether classically acting only on the morphine in mu1 receptors, which, next slide please, which can act basically for analgesia. But morphine receptors are basically present in the brainstem level, of course all over the central nervous system, but primarily in terms of brainstem level. And this morphine receptors, there are two types, mu1 and mu2. The mu1 morphine mu1 receptor is primarily responsible for analgesia, while mu2 will also have these problems which we are facing in terms of addiction, in terms of euphoria, in terms of other side effects like hallucination and excessive sedation and narcosis. So what we want? We want a molecule which will act on analgesia but have the minimum effect on the other side effect of the other receptor. And hence they are classified as agonist, means which will take care of the analgesia, and antagonist, which will take care of the side effect profile. The major receptors like morphine, pethidine, and they are basically agonists. They don't have any antagonist activity. So they primarily lead to, over a period of time, as we know, to addiction and acutely in respiratory depression and on. So if you come, so now we have two types. Go back to the slide. We have two types which are basically agonist, but also have an antagonist activity. They are known as agonist. Next slide, previous slide. They are known as agonist plus antagonist activity. Previous slide. इसके previous. तो आगे जा रहा है. So the agonist as well as antagonist activity are those mixed agonist antagonist. So they have agonist activity for the analgesia. Next one, have an analgesia, but antagonist activity against mu2 receptors and all. So you don't have respiratory depression, meiosis and all. So of this particular molecule, we have two molecules. One is a fentanyl molecule, and second, the newer one, and not exactly newer one, and it was found out in 1978. In the 50s, fentanyl was found out. So we have this particular molecule, which is known as butorphanol. Also, it looked at the action of the molecules and the side effect profile. You see morphine, fentanyl, buprenorphine, basically they are agonist, minimum antagonist activity. So they have primary analgesia, but at the same time respiratory. Antagonist activity also, as you escalate the load, there could be a ceiling effect, like when the pain effect will not go away, but the respiratory depression and all will not rise, and basically it will go down. So this is the advantage of having a mixed agonist and antagonist, and you have basically a fentanyl and butorphanol as the two molecules. Quickly, give me 10 minutes, right, and I will tell you, not in the anesthetic role, but as a surgeon role, where you would like to use this particular molecule so that your post-operative pain within the first 12 hours and 24 hours, or the patient has maximum relief and doesn't come back to you or start shouting, I'm not okay. You know, the burden goes on the surgeon. And surgery has been perfect, very good, but my pain is not gone away. And is this post-operative pain, we divide into first 12 hours and first 24 hours. A recent paper from Tanzania itself has compared the molecule which used, one was fentanyl and tramadol, and they found 90% of the patient were unhappy with the pain control in the first 12 and 24 hours. And this is also true in our country and internationally. Internationally, the score was up to 65%. In today's time, we don't have a post-operative pain in relief molecule, which we as doctors, physicians can give safely and still control the pain. And my personal experience, when I broke my arm, it was so, they were giving me paracetamol 6 hourly, and as you all know, it was not easy for the pain to go away, and I refused to take fentanyl and all. I said, no, I'm going to not going to petidine, fentanyl. Don't give me, because 1 or 2 injections of fentanyl and petidine can lead to basically addiction, which we all of us have as a personal experience. So now let's compare. So we have a molecule which is an agonist and antagonist. I will not use the word butorphanol, but agonist and antagonist. And we have a molecule which are primarily agonist and very minimal antagonist activity. And presently, we are basically using primary agonist activity at suboptimal doses. Hence, the pain is not there. We are not saying that morphine and fentanyl and petidine will not relieve the pain, but at the optimal dose when you go, depending on the patient and the surgery, the chances of the respiratory issue and other will go up, especially basically here. So here we have a molecule, both agonist and antagonist, by name of butorphanol. It is available as injection. It will be available as tablets. It is available as a nasal spray. But probably today in Tanzania for the first time is butorphanol. We launched this in India also first time as an injectable one, but then other organizations have brought into a tablet as well as a nasal spray. So tablet and these nasal spray and patches will be for long-term pain control. For a short-term pain control, here you have a molecule which is 7 times of morphine, 40 times of pitidine, 20 times of pentazocine, with probably a better analgesic activity or an equipotent analgesic activity at the dose schedule. Only 2 milligram, only 2 milligram of molecule versus 10, 40, and 80 milligram, which makes us also feel very safe, makes our nurses also feel very safe. And it can be given in intravenous and as well as IM intravenous rapid. Intravenous bolus, it can be given. If you want to give fentanyl and all, you over a period of time, what you are talking, you have to give it in a IV drip form. Next. So, in how long, the question which arises in our mind, how fast is it going to act? If you give IV, it is going to act within 5 minutes. If you give it IM, it will take 30 minutes. And it is short acting. It lasts for only 3 to 4 hours. So if you want to give subsequent, you will have to give it every 6 hourly and all. But I will show you a way out when you don't have to give every 6 hourly, but as an IV infusion, you can start and forget about it. So respiratory depression effect, here is the data available to us that butyrophenol and pentazocine basically have a ceiling effect, what I was telling you. You start the dose starts, the pain killing dose, the relief dose starts from 0.5 milligram and up till 4 milligram, the pain effect is there. At 4 milligram, the whatever respiratory depression has to occur will occur up till 4 milligram. And then there will be a bell-shaped curve when the respiratory effect will go down, but your analgesic effect will less. Even if you step it up to 6 to 8 milligram, I don't say step it up to 6 to 8 milligram, because then narcosis will occur, the sedation will be very high, even if the patient doesn't have a respiratory depression. So as we move forward, in terms of analgesic activity, both 10 milligram and 2 milligram of molecule butyrophenol is basically same. Next. As I said, in terms of butyrophenol and sedation, the sedation is so that the patient is awake. Patient is sedated, but patient is basically awake, which we want especially in neurosurgery, especially sometimes of orthopedic surgery, when you do knee replacement and all, you want the patient awake and let him show on the video, what you are doing. So he's basically sedated, but not in a narcotic state. So that is known as conscious sedation. We are sedating him, but the patient is conscious enough to answer the question. Does it pain you? Doesn't it pain you? You also know when you're doing orthopedic how much local analgesics you are infiltrating. That also ideas you will get with the pain. The nausea and vomiting which happens, tramadol is quite well known. If you step a tramadol to 100 milligram and all IV I'm talking of, nausea and vomiting is a part of it. So we give anti-vomiting agent like ondansetron or something to control the pain. Here the nausea is less. So these are the various benefits occurred. There is no constipation, there is no euphoria. Even if the injection goes out, there is no tissue necrosis which are there. And it has got an antitussive effect, also the post-operative areas as a pre-anesthetic medication, and it's part of a balanced anesthesia. It can be given, and so that intubation and all become smoother, or during labor it can be used. What we talk in terms of pain. Is asking me, please, what about the dosage and administration? And it's very simple. 0.5 milligram you start. It's available as a 1 milligram and 2 milligram ampule per ml. Correct? If am I right? Yes, 1 ml and 2 ml, which 0.5 and 1 milligram ampules it is available. You give slowly IV or as a bolus slowly. Best to dilute it. If you don't want to dilute it in a hurry, you can do that. But always in all IV opioids, non-narcotic, narcotic has to be given on a slow basis, depending on different types of patient we have. So I always tell my staff, dilute it, 8 and 5 ml, 10 ml, and slowly give till the patient gets really, if it may be even less than 0.5 milligram in elderly patient with other other comorbidities also. If you want to give pre-anesthetic, you're a small nursing home, you're in a deep somewhere else, and your anesthesia, you don't know when the anesthetic is going to come in or you can give intramuscularly around 60 minutes before. Also, by the time the anesthetic comes, at least the pain is getting relieved, especially in your scenario. Or still the guy comes and start, it will help his anesthesia, his anesthesia also. So of the various indication of the butyrophenol, all in terms of pre-anesthesia, regional anesthesia, you can give it as a form of peripheral nerve blocks, ganglion nerve blocks, epidural, or intrathecal, caudal, everywhere. All this is data is available. Well, I'm sure, or you can reach out to me whenever you want. All this data would be given it to you. And now we are talking in terms of go back. We are talking in terms of alternative to paracetamol, to tramadol, to NSAID, which doesn't give us the dose of IV immediately, and it's 0.5 milligram, and the pain disappears. And in fractures here, it will be of great help, and especially if you make it as a part of a protocol. Can any fracture come before I come? If the pain is there, intramuscular, we can lower limb surgery, brachial plexus block, continuous brachial plexus infusion, periosteal blocks, adductor canal blocks, which are given to us epidural ones, and patient control analgesia. This is which I want you to go back and use it. Any scenarios which you have, you can dilute 4 milligram in 50 to 100 ml, and at a rate of 0.5 milligram per hour, you can give the patient and let the patient control himself how much amount of fluid and molecule if the patient wants to go. So in post-operative pain, we have already discussed, and the various highlights of the molecules I have already told you. Especially, addiction potential is low, nausea vomiting is low, euphoria is low, or respiratory depression is also low. Lastly, a caution: don't use it when the patient has got poor ejection fraction in the cardiovascular scenarios, because it increases the pulmonary pressure and may lead to congestive failure. So in a cardiovascular scenarios, that molecule need not to be used. Otherwise, it can be used very, very safely in usual surgical procedures, which you look at on a daily basis. Thank you very much for giving me this time. I'm impatient to hear me all. Thank you very much.
My name is Randir Bhivankar, and I'm the Senior Regional Sales Manager for Aristo Pharmaceuticals. Thanks to the Tanzania Orthopedic Association for giving us this platform and helping us launch our Butrum in this part of the world. Let me assure each one of you that we are the first company to introduce Butrum. So I would say that we are the pioneers of Butrum in Tanzania. So the originator brand has gone off patent. So we have launched Butrum in Tanzania. It is registered with the TMDA. So I would request each one of you to give the wholehearted prescription support for Butrum. And whenever you need the molecule, it is available with our distributor, Planet Pharmaceuticals. So they have this here in this country. It is available already. And the monographs have been given. So those of you who have not received the monographs, we have our booth. So make sure that you all have the monographs. So thank you very much.
We thank you, the Aristo Company, for introducing the butorphanol. Maybe one comment or question. What's your comment about multimodal pain management when using butorphanol? Multimodal pain management.
In multimodal pain management, we use lower doses. You can use a fentanyl, you can use butorphanol, you can use pethidine, or morphine, even NSAID like ketorolac. You can combine, but the dosage will be less, hence the side effect profile will be less.
Thanks. Question?
Sorry, sir, I couldn't get the question.
Is it a synthetic compound or is it a plant extract?
Sorry, sir. Sorry, I am little difficult here. Yeah. Yeah. Yeah, this is purely synthetic. In a laboratory, like a fentanyl, it is not an extract. Very nice. Thank you very much for bringing up this question. It is not an extract of poppy seed or anything. It's not a opioid, in the classical terms of the term. It is synthetic, which acts like an opioid.
One more. And thank you so much, Dr. Bandukwala, for your eloquent talk and introduction of the molecule. Karibu sana Tanzania. So we move on to the next talk, the next three talks, and we will welcome Dr. Fire to chair these talks. Welcome Dr. Fire to chair these talks. The first talk will be by Dr. Nungu, Controversies in Orthopedic Surgical Management, will be followed by Dr. Shindo Kilawa with a case report about below knee amputation in polytrauma. And final talk will be again by Dr. Professor Bill Haonga, unification of the schemes with Still Anderson and the Orthopedic Trauma Association in open fracture management. Karibu sana, Dr. Nungu.
Thank you.
Thank you. My talk to you today will be is ideally to stimulate a discussion at the end and at least also to build the confidence in some of our colleagues sitting around. Of course, as orthopods, our main interest in treating patients is to alleviate pain and restore function. Those are the two main aims of our treatment. Also, there's a third one of aesthetic, but for me, it's always relieve pain and restore function. Controversies which we see in the management of our cases are especially based on opinion indifference. My talk is going to be on controversies, or my talk is based on controversies, then opinion differences, and also I'll talk about the pathway in decision making, and then at the end, I'll give an example why I was estimated to give this talk. That is my talk today. Controversies often revolve around best practices that we have, and then also based on the use of new technologies that come, they can lead to controversies, and also because of varying interpretations of clinical data. This is where we get controversies from. Notable areas of controversy, especially in our patient, whether to have surgical versus non-surgical treatment. This we come to see in the fractures, for example, fractures of the clavicle, fractures of the proximal humerus. There are controversies there. Then you can have controversies in pain management and opioid use, where we have postoperative pain, and where we're also afraid of, or sometimes we think of dependency in opioid use in our protocols, postoperative management protocol, pain management protocol. There are also notable controversies in the use of imaging technologies, for example, the use of PRP and stem cell in the treatment of tendinitis. Also, you can have controversies in implant choice, where, for example, in total hip arthroplasty, the use of implant choices in the use of liners, cross-linked liner or the normal polyethylene liner, that can cause us also as a basis of controversy. Timing of surgery, especially people doing ACL reconstruction, whether it should be done early or delayed. In rehabilitation protocols, we have controversies in the intensity and the timing of physiotherapy, and also can be in the number of the use of number of follow-ups, and also either to have a number of limitation of X-rays to be done. That can also be can cause a controversy, and also the cost benefit of that type of procedure can also raise some controversy. However, also we have individual opinion which can which can differ from person to person, but that is not a controversy, but it is a question of an individual opinion where we can differ, and that's a bit of orthopedics or that a bit of surgery. The varying opinions can be influenced by surgeon's experience. It depends to the surgeon at which training and his experience. Patient condition at the time of surgery can have different can lead to different opinion. The variable technology that we have by that time, for example, when we have some years back, we didn't have arthroplasty. We had other types of procedures which you could make with giving good results. But now with the new technologies, it can lead to some different varying opinions, or the variable or the variability of implants also can lead to varying opinions, because some implants are not available now, but we are very successful before, but now they're not available. So it can give different opinions, or evolving research which comes up with some different opinions. Because as here I'm referring different opinions. For example, in total arthroplasty approaches. When it comes to approaches, we have different depending to where someone is trained. There are people who would like to go a direct anterior approach, or lateral approach, or posterior approach. Each approach has its own pros and cons, but depends where one is trained and what one is interested in. Can be in ACL reconstruction techniques, for example. There are people who would like to reconstruct. The people who would like to reconstruct or to repair or reconstruct ACL. It can come in also different opinions in spinal fusion techniques. So one would like to go posteriorly, others would like to go anteriorly because of the differences. Anterior approach, you have direct vision or direct approach to the disc. You know, the posterior approach, you can decompress better the nerves. So that is a question of opinion. In rotator cuff repair, we have people would like to do it arthroscopically, and others would like to do it openly, especially in massive rotator cuff tear, where one sees it can have better reconstruction in open surgery, because you see and have a strong fixation of the massive rotator cuff tear. In the pediatric orthopedics, also we have can be opinions, different opinions in pediatric fractures, especially epiphysio fractures, where one would like to operate and others would like to treat conservatively because of the alignment that one gets. But this is a case where we have, for example, a case I'm presenting to you. Now, the opinion here, which I'm talking about, the surgeon's experience can. I have a case which I'm presenting to you now, as I said, an example. What would one like to do to this patient? That's what that led to me to make this presentation. What approach would one like to use to handle this patient? This is a young patient. I think he was 32 years of age or less than that. Had pains for 3 years. Of course, the decision will depend on the surgeon's experience and the training. will depend on the available technology and implants, as I have said. It will depend on the evidence-based medicine to get the best treatment for this patient. It will depend on patient factors, that as I said, as age and the comorbidities. But not the least, will depend on the financial capability. However, how far we can run away from that, it is always haunting us, the financial capability of that patient in question. Now, the alternatives we have, for me here, I see we have three alternatives. This is where we can discuss. Amongst you, I think everybody sees that this patient would benefit from a total hip replacement for sure. That's the best alternative that we have. But also, there are some other alternatives which we can think about. We can think about the resection arthroplasty. We can think about the fusion of this hip. These are the three alternatives that we can have. It's not, there are so many cases that we see in our country here with such a situation whereby people come with so much pain for some years, 3, 4, 5 years, having pain in the hip, not able to do reasonable work which they have been doing, having problems not enjoying even their family life at home, and they're in pain. They need help. See, this is just an example of a 44-year-old patient who had pain for about 3 or 4 years, moving around trying to get help, just being given analgesics. But this patient must be helped. The picture I showed before, our treatment which you looked at, is mostly based on the X-ray that we see, not the patient. We look at the X-ray and we make our decision based on the X-ray, not based on the patient. Here I'd like to say that we have always to prioritize in the patient's best interest. That's where we should look at. The decision must be patient-centered. There must be clear communication to the patient, telling him or her of the benefits and the advantages and disadvantages of the procedure which you want to do. We must give him a comprehensive risk assessment of the procedure you want to do, the possible complications that we can get, the fractures that we can get when we fix, the infection that we can get. We must talk of, we must discuss in groups to get possible results. We must also not forget about accessibility of that type of procedure you want to do. As I said, for that case, we have resection arthroplasty. We can do total hip replacement, but also another, we can do fusion, as one which you see there. When you talk of fusion, I've gone through our implants to see in an institution like Moi. Right now, there are very few plates like Cobra plate, which used. The older guys understand the Cobra plate, how we used it. But in the younger generation, most of you have not seen fusion, hip fusion with a Cobra plate. But we used the Cobra plate with good results, which you don't see now. But for me, I still see it as a viable procedure because the interest in our treating patient is to relieve pain and restore function. That is, thank you. I wanted to stimulate a discussion. I would like to hear what you want to talk about it, and also to build the confidence in some of our young guys. For me, this plate, for example, Cobra plate fusion, the patient with so much pain, and having orthopedic surgeons around in the RRH, as it is said, is a viable procedure rather than sending this patient to a central hospital for total hip replacement, which one road will not get because of accessibility to financial accessibility. I would not hesitate to fuse one side leaving the other side functional, or if we can get a prosthesis and he will be free from pain, enjoy his life, I think it would give better results. Thank you very much.
Thank you, Dr. Ndong. We treat the patient. We don't treat the x-rays. Please, I will repeat that statement many times. We make that error. We treat the patient. We don't treat x-rays or any other radiological finding. But it's a common mistake we make. We'll go to the next presentation. We'll have the discussions at the third presentation. Please report. Please report. Yes.
Good afternoon. Okay, I'll take you through this case presentation. A life-saving below the amputation of severely crushed leg in a polytrauma patient. I, Dr. Clow, is a presenter. These are my outlines, introduction, case presentation. Thank you, I'm sorry. So these are my outlines, introduction, a case presentation itself, discussion, conclusion, and references. So the introduction, mangled extremities injuries are the devastating injuries that is associated with the shock and sometimes can cause a multiple organ failure and it can lead to death. So it's a layer to the young female compared to the young male patients, because these young patients, young male patients are being involved in high risky activities. And these injuries poses the challenges on decision making, whether to do amputation or to do a limb salvage. A life-saving procedure is the main goal for severe injury lower extremities. So you should consider the life-saving and not a limb-saving first. So that's the message. So I'm presenting to you a case of 22 years old female who presented with a complaint of right leg injury, crash injury, and also has the head injury and the pelvic injury. It was 30 minutes prior to admission. She was being knocked by a motorbike when she was during the morning parade as a military. So she developed the dizziness, thirsting, and also she developed confusion and heartbeat awareness, and also general malaise soon after injury. There were no vomiting, no severe headache, and no bleeding by ear, nose, and the throat, and the past medical history were unremarkable. So on examination, this patient was confused with GSS of 14 over 15, and she was paper white, and the blood pressure was 75 over 45, and also the pulse rate was 122 beats per minute, and the respiratory rate was 26 beats per minute, with cold extremities. And for the local examination, this patient has a deformed limb, right leg, with a circumferential wound, with a crushed muscles. It was a severe crushed, and the bones were being exposed with active bleeding. Although, however, they have tied it with the clothes. So the distal pulsation were not present, and we scored MES score, mangled extremity score of 8. We have done a full body picture, and she has HB of 8, and hematocrit of 22, and also she has hyponatremia, which is mild hyponatremia. These are the pictures you can see. The first picture, it's a picture that we took during the examination, and these are the pictures that we took in theater during the procedure. And you can see these bones are severe crushed, and also the muscles were not viable. And here, this is if you look at the X-rays, the you can see it's just an innocent X-ray, but if you go in, it was not an innocent X-ray. It was very severe, actually, for the mid segment fracture. And also, this patient has a fracture to the pelvis. So we made a diagnosis of open segmental comminuted fracture of the right tibia with Gustro-Anderson classification 3C. And also, we had it also for hypoglycemic shock, mild TBI, hyponatremia, and the left obturator ring, right superior pubic ramus fractures, and the sacroiliac joint subluxation. So we managed the treatment of this patient. So we managed it with a multidisciplinary team who were being involved very urgent at images. So we continued bleeding following the advanced trauma life support. After resuscitation of this patient, we have given the tetanus toxoid and analgesics and antibiotics. So after resuscitation, we opted to go for surgical debridement and external fixation. We are thinking to do this damage control orthopedic. So while in theater, we found the limb was unsalvageable. So we decided to do guillotine amputation the same day. After the amputation, we went in again within 48 hours for second look, and our patient stayed in the ICU for 3 days. And later on, after the patient being very stable, we transferred her to surgical. Then 2 weeks later, the patient developed an infection while in the ward. So we went in again for debridement, and we kept this patient on antibiotics for 2 weeks after a culture sensitivity. So ceftriaxone was one of the sensitive medicine that we kept in. And the stem later on granulated, and we did a skin graft. After we have done the skin graft, the patient, the wound was healed well. However, later on, she developed the infection again. These are the pictures you can see. This is the one after the infection, and this is the second one showing the granulation, and this below showing the skin graft that we did. So after the infection she developed, we did a culture sensitivity, and we found that vancomycin was the one we used, the one drug we used to treat this patient. So after we did that, later on we did standard stump closure with immediate postoperative prosthesis. During that, the patient started to do physiotherapy, and fabrication of this prosthesis was ongoing. The wound after this IPOP, the wound was healed after 2 weeks, and the patient now is well. The pelvis fractures was being managed conservatively. So you can see this picture. The first one showing the standard stump closure that we did. After then, this is the second one showing when we were doing the IPOP, and this one the healed one, and this is the picture showing how we made that prosthesis. This is the patient currently. And this one, sorry. This, as you can see, the patient now is walking. Okay. Okay. So I want to show you the video on how currently the patient is doing. but unfortunately the video is not displaying. So here the message is we should be on patient concentration, but not on the limb. Most of the orthopedic surgeons are concentrating on the limb management instead of concentrating on the patient management. Okay, discussion.
Going to move on to the next presentation Dr. Mohammed was saying. I think this is a very important area. Is artificial intelligence going to replace us? Will the doctor, will the surgeon be redundant? Let's see what our friend has to say.
So, good afternoon, everybody. Dr. Faya taught us today that you have to sort out the 3 basic needs: food, shelter, clothing. Now, I stand between all of you and one of those needs. This is the last talk before lunch. It's normally the hardest one to give because everybody is just hungry. Come on, just finish it. So, with that respect, can we all stand up for 10 seconds, stretch ourselves, and brace ourselves for the next 10 minutes? Just as we continue to sit down, there's an announcement from the organizing team. Kindly make sure your MCT number is filled accordingly, appropriately, and correctly. Kindly make sure your MCT number, there is a form that is going around, make sure your MCT number is being filled as per how it appears. And name, of course. The name always comes first. Okay, good. So, no conflicts of interest to declare. The objectives of the next 10 minutes are to understand what artificial intelligence is, how it promotes healthcare, if at all it does, and how it can promote orthopedic related care to our patients and take home messages. So the question is, let me take you back to the future. It's 2050 and there are robots treating patients all around. The healthcare facility is invaded by robots. This is an example of, which movie is this? Robocop, excellent. The other one? Transformers, yes. So this is a picture that we normally have when we hear of artificial intelligence that will be replaced. The surgeon will be replaced. There is robotic knee arthroplasty, robotic hip arthroplasty. So then the work of the surgeon will reduce, and of course the take-home financial gains will also reduce. But is that the case? How many of us have ever used some form of artificial intelligence in our lives? Raise your hands. Actually, we all have. How? Good. Facebook, Instagram, YouTube. The ones you search on, for example, if I like a particular entertainer or musician, Diamond or whoever, the next time I go on YouTube, it will suggest me what to watch. I will not have to type it. What is that? It has identified a pattern of what you are searching for, and the next time you go on YouTube, you search for orthopedic procedure because it's a trauma patient who you have no idea how to do the procedure, and then you YouTube it. So the next time you go on YouTube or even on your Facebook, because these are all linked. So what artificial intelligence is just basically simulation of the human intelligence to machines. So for example, how human beings think is I make a process, I have some knowledge, I learn through experience, and then I make a decision. So it's basically trying to assist the machine to do your job and help you in doing a better job. That is what artificial intelligence is. Artificial intelligence is great at many things and not so great at a few things. It is very good at augmentation and aggregation. So for example, an automation. So for example, I have taught the machine to do particular form of thing. It will do exactly the same thing every time that scenario happens. But there's also a byway. So I can ask the machine to do a certain task, and then once it does it, it sends the feedback to me. Then I, as a surgeon, make the decision on how to proceed. It doesn't make the decision for me. It assists me to be able to make an appropriate decision. Healthcare and artificial intelligence. What's the scenario? What's the situation? It helps us to individualize the healthcare. How? We as surgeons, we see so many patients a day. It's very hard for us to be able to know the genetic background, the history of the patient, the medical history, gynecological history, surgical history, medical history, allergy. But what this does, it identifies from the data that we feed. I'll talk about data just in a while. Data is extremely important. Without data, there is no AI. AI feeds on the data that it is given and produces the results. So without data, without a trauma registry, AI cannot be here in Tanzania. It's extremely important. Healthcare providers, how does it help us? It reduces the burden that we have. I hate writing notes. It takes a lot of time. I have the NHI forms to fill. I have the system to fill. I have to talk to the patient. So we forget talking to patient. Out of the 10 minutes that maybe we see one patient who has waited 6 hours or even 2 days to see us, or has traveled for many hundred kilometers, who have come to us, I am hushing and I'm in a hurry to write notes, fill the NHI forms so that I don't get rejected. We forget interaction with the patient. AI can help in that. It can reduce burnout. It can reduce the burden on the healthcare providers, be it the nurses, be it the doctors, be it the surgeons. Accuracy is also very important. We'll talk about it when we come to orthopedic, but it also gives an algorithm of prediction. So not only does it help to diagnose, it also helps to predict what problem may arise. There was a study done on AI, how it helps to detect sepsis. And clinical parameters took 6 hours more so that you can say, okay, this patient will likely get sepsis. AI was good enough to give the prediction that the patient will go into sepsis 6 hours earlier, which is very important. Drug discovery and medical research. Research, who amongst us has used ChatGPT? ChatGPT. Yeah, it's a very good tool, but sometimes it gives you things which are not there. Hallucination. What is hallucination? ChatGPT, hallucination. There was a person from Mayo Clinic who I was listening to. He said that I was doing this research and I went to ChatGPT and I asked it which researches are being done in this particular town with this topic that I'm going to do. It gave so many results, but he said no, but I don't know of these results. If they were happening, I would be knowing the researches. Actually, it was a hallucination because it's all about the algorithms. So it hallucinated that these researches were taking place, but actually they were not. So that we have to take care of. The other part is the patients that come to us. Even if we are not using ChatGPT, they are definitely using ChatGPT. So they will come with a lot of medical diagnosis. There actually are some hospitals in the West that has a clause saying that you will how you will use ChatGPT, and they actually train for it. It's important. For example, if a patient comes with low back pain, you can write, okay, what are the causes of low back pain? You remember 39, but maybe there's one you may have forgotten. It can remind us. But of course, there are risks to technology. When you come to orthopedics, it's the whole range from diagnosing, treatment, and prevention of complications. How does it do that? Mayo Clinic, as an example, has all the arthroplasty registry from 2000 to 2020. During the 20 period, they have over data of 30,000 patients with x-rays, with history, and 300,000 x-rays more that have not done the arthroplasty or not required arthroplasty. So what it does, if a patient comes there, they put an x-ray, it can actually diagnose. Sometimes the radiologist, or sometimes we're in a hurry so we don't see or oversee something. But what AI can do is give an accurate diagnosis. This example was given. The X-ray that you see on your left, the first one is 3 months post-op. The second one is 2 years post-op. So the results, the radiologist results were left THA, no evidence of loosening, degenerative arthritis. But Mayo Clinic have devised a system in which it reports up to 22 things which are mentioned in regards to X-ray of the pelvis and hip. Calculation of the subsidence. Again, similar X-ray, 3 months post-op on your left, and the second one is 2 years. It gave an accuracy of measuring subsidence by 0.1 millimeter. The surgeon could only see if there's a difference of 0.3 millimeter, but because this is an automated thing, it predicts 0.1 millimeter. In how many seconds? 0.8 seconds, less than a second. Those gurus of arthroplasty worried about two things: dislocation and periprosthetic fracture. They have so there's an algorithm that is formed to show you the risk. So we have the studies, but they have made algorithms to show us the risk. And the main thing here is the modifiable discs, modifiable risk and non-modifiable risk. But the most important thing that we will deal with is the risk modification by the surgeon. For example, if you have a patient who's 8 years old, some comorbid conditions, you enter the BMI, a past medical history, it will actually tell you the risk of dislocation is up to 9% if you use a less than 32 millimeter standard type. But if you use more than 36 dual mobility, you can, with the approach, the posterior approach, lateral and anterior, you can reduce the risk by 3 folds, less than 3% from a risk of 9%. Similarly to the periprosthetic fracture, if you use a non-colored, non-cemented, the risk of periprosthetic fracture is up to 10%. But if you do that in a colored cemented anterior approach, it can be as less than 1.2%. Finally, it also can synthesize the X-ray. So you have a patient, or you have an X-ray of a patient who needs a total hip replacement, and there are different systems that you have in the system. So for example, Mayo Clinic uses 8 different types of femoral stems. It can actually give you a post-op picture. It is synthesized. There's a way how they've done it. These are all pseudo X-rays. They are not real X-rays of a patient. They've given you a post-op provisional X-ray of a patient whose surgery is not done. And this one is the actual post-op. So the take-home message is artificial intelligence will never replace doctors and will never replace surgeons, but they can assist us for the betterment of the healthcare and the betterment of our patients by diagnosing it better, planning, and having better outcomes for the patients. The future is now. Thank you very much.
I'm still around. I thought I was going to be displaced. But always remember, you are the one who has the patient. It's not the computer. You are the one who has the patient. You are the one who is assessing the patient, not the computer. You use it to add. Now, any comments, questions to Dr. Lungu? But controversies. Some of us are old generation, some are new generation. The new generation fix everything. Get a fracture, fix it. The older generation.
Thank you, all presenters, for good presentation. My question or comment to Dr. Nungu, I'd like just to comment that the evolution of treatment. First, for the patient you presented with osteoarthrosis bilaterally. Because if you see the evolution of treatment of such a patient, in those old days, started with medical treatment, medication for pain. So because as you put it clearly, the patient problem is, in most cases, it will be pain and pain management. Then it comes the era of osteotomy, different types, the rotational osteotomy and so forth. And then as we went on, we came to medicine or surgery was very advanced, and we start doing replacement. And here there are people who are really crazy in replacers, so who would like to replace. I'm not probably one, or I may be one. And then now I'm asking myself, when it comes a question of the age of the patient, for all the patients, there's no doubt one who has 60, 70, there's no doubt one will go to a replacement will be the probably the best option. But when they are young patients, 13, their 30s, 40s, then that's where really a controversy may exist, because with the replacement we are talking of survivorship, prosthetic survivorship of ranging 10 years, 15 or 20. If we are at 30 or 40, how many replacements are you going to do before you reach 70, 80, and few we are praying to go to 90 or even more? So when such a young patient, probably one would opt for some kind of replacement. I'd like others to comment also who have done this recently, is the rotational osteotomy. What's the place in this? And probably as the age advances, then one can go to replacement. So because again, with the arthrodesis we are talking about, the cobra plate, yes, there are times we did a lot of them, but again, you see, when you fix the joint at certain angles, and for young patients who are really mobile, they are limited in some activities. They are limited. That's why I'm talking of, just wanted to comment about rotation osteotomies before coming to replacement afterwards, as the age advances.
So shall we take the questions first? Okay. Sharif?
Thank you, Mr. Chairman. My friend Dr. Nungu here presented with an X-ray that normally I would say refer him to your best friend. I would not even think twice. This is the X-ray. Definitely, this is a very bad X-ray by all means. And quickest solution that one would come to is hip replacement, total hip replacement. But then in a case like this, when you have both the left and the right, they are involved, there are a lot of things which one would like to know for making up a decision, any decision. Which side is not true? They are both painful, but one is more painful than the other. In my gut feeling, my gut experience, is that usually the one which looks slightly better in the X-ray would be the one which is more painful, and the one which looks very bad in the X-ray would be the one what the patient would say, 2 years ago this was too painful, but now I can handle this pain and I cannot handle this pain anymore. So those are the things which include in the controversies which the family is talking about. When we want to make any type of decision as final treatment, definitely these are things which we need to know. My challenge, or rather my question to the audience is we should come up with there will be medical come up to one consensus which would help the patient. So I leave it to the others to tell us what would be their thought about this kind of.
Okay. Any other comment? Please pass the mic to Professor.
Yeah, thank you very much. From the presenter's part, I'll start with Dr. Nungu. Yes, there are controversies when you are living in a country where, as you said, maybe accessibility could be an issue. As if you have a patient like that in our country with the accessibility to joint replacement what we have, as Sharif is saying, for sure this is the patient you want to replace. And again, take what is more painful. Of course, the age is an issue, but with development in science, if you go into evidence available now, the implant design have changed a lot to increase the survival. We were used to cemented. People went to hybrid and completely uncemented poly with so many issues. But now people have moved to poly and ceramic, which to some extent improve the quality and outcome. So yes, there's a lot of development in technologies. Artificial intelligence is coming as well on a joint replacement. So if you're in an area where you have resource limited, yes, the controversies will be many. But as we are moving with this development in economy, these are the patients which is somewhere there's a problem. Seeing that patient at this development now and nothing has been done, then either there's negligence from the patient himself or the doctor who saw the patient, he neglected the patient. Otherwise, something could have been done to like prolong the life of the native joint. That's one. I want to go to Dr. Mlawa, Kilawa. Okay. I'll be a patient who came to you 30 minutes after injury. You should be very lucky to get a patient at that time. I was saying, this is very early. They come 4 hours, 5 hours after injury, which your message score could have been high. But I'm seeing like you went straight with your message score and amputation. Patient who is a distal part of the leg injured, no matter how severe it is, I think the ankle blocker index, now these are the controversies, the same. The ankle blocker index could have been done. And then you say, no, this is the status, and do I need a Doppler or any other vascular advance investigation to confirm that? Okay, amputation is justifiable. So we have that experience at Moy where you get a patient with score of 8, 9, and they survive. Well, other people say, no, it's a straight amputation. But again, the development in technology, I don't know whether that was taken on board, that fine, it looks nasty, but let's do ankle blocker index. After that, go for some other vascular assessment to be sure that, yes, we are dealing with a patient whom the vessels are gone and perhaps is a senseless limb and proceeds amputation.
Just to add on to that, there have got to be several of you making the same decision. That is to avoid litigation. Don't make that decision alone. A number of experts, if you can get another colleague who is an orthopod, take a look and give you the same kind of amputate. You have a backing. When you're alone, you're alone. People can take up litigation measures against it. Next. Any more comments? How about on IR? You have one?
Yeah, thank you very much. Questions to Dr. Kilao and then Dr. Mohammed. One is on the introp finding or decision to make amputation. I wanted to be clear whether the decision for amputation was made preoperatively or intraoperatively, because we know that the decision for amputation is a one-way traffic. And in the emergency assessment, it's crucial to make such a decision and counsel the patient preoperatively. So the decision made before, or was it an intraoperative surprise? And because there are scores and there are ways to assess and know that this limb may not survive. And the second question is, I just want to know the circumstances. This is a very good case presentation. I just want to know the circumstances under which the patient was knocked by a motorcycle, because I have interest on that, as we'll see in the next talk. Again, Mohammed, on AI, there are so many things on AI. But you train and you work around MOI as well. And looking on our circumstances, are we at the right time in 2024 right now, talking of MOI and other hospitals, especially government hospitals, to employ robotic surgery as a form of AI as of 2024? That's my question.
Thank you. Shall we stop here and see if we can get some answers? No. You have some answers.
Thank you. In my presentation, in actual fact, I took up this case because we had a case on which I presented, and I stood for fusion, because, as I said, the decision when you're treating a patient is on the X-ray you're treating, not your mind. The patient should be in center. Everything should be patient focused, listening to his or her needs, her preferences, and her overall health. Now, a patient who has been moving around with the pain for about 3 years, 4 years with the pain, and you see, you want to give him some sort of relief. There is the question also of accessibility. This patient has no chance. This patient has no chance, as you see, of financial problems to take care of the type of procedure that you think in your mind that you can offer. Then you must listen to that this patient, find a way, something that can be of use to the patient. Now, when I come to my experience, personal experience, I've fused a girl at the age of 9. By that 21, 22 years ago, we had no way someone who came with a AVN because of sickle cell, 9 years old, what one could do. The chance was there was resection, just removing that hair. But imagine a 9-year-old girl, what would be her life? I fused that joint, the one which you saw here. She was sent to me from Pemba. I fused that girl at 9 years of age. The mother, after time when they used to come for follow-up, was wondering about the girl, how her life would be. She went to school, playing with other kids, running around, got used to that type of fixation. I told the mother that she will have a normal life. 1 year ago, I was called to be, and I told the mother that I'll be there the day she gets married. I have a picture, if you can go ahead, you put it down. At 22 years of age, there was a wedding. I went to attend that wedding. She was married, and she has a child already with a normal life. When you fuse the joint, you relieve pain. Function in young adults, as you say, they get used that position, but then the other hip, you can wait now to see if it can be arthroplasty can be done in the other hip. But you have already given chance for that person to have at least a painless hip. And as I said, it is stated to go one step up from another step. Even fusion, you can reconvert it into a functional hip later on, if conditions, and depending on the patient's financial position and also need. There must be a need. What you are trying to treat is the need. And when the patient comes to you, by that time it is pain. You have to take care of that pain. I find it very difficult sending a patient to somewhere to beg for help, which will come not immediately, but will take time. And moreover, you're not sure if he or she will get that help. So I find it reasonable once the patient is once the patient agrees, having convinced the patient or talked to the patient, and she sees that he would prefer that procedure, I go ahead with that procedure. That's what I thought. And of course, with the new technology in arthroplasty, still the risk of the operation is roaming around. After a certain period, be it 20 years or what, there is that risk. Are you sure that patient will get that help which you're talking about? Are you sure this patient, that commitment of living those 20 years? Why don't you give this patient a better life, painless life during this period that the patient is living? That's why I propose that. Thank you. I don't want to treat our mind. We treat the patient in front of you, what he or she needs by that time.
There was a question thrown to you.
Thank you for the nice comments and a nice question. I'll start to respond to the question. The first one is the circumstance, what happened to this patient. This patient was on a military training. So while they were on along the road, they were on the normal parade along the road. So one of the motorbike knocked them while on the road. So one of the colleague who was with this patient was died while on the way come to the hospital due to this motor traffic crash. So the motor traffic, this motorbike knocked the three person on that circumstance. So we received one patient who was died on the spot, and the one patient is this one who did amputation. And for the second question, the amputation, the decision for amputation, we did discussion to the patient, and the family, and also the doctor who escorted that patient from the military. So on the discussion, we did a discussion on the amputation, possible amputation, and the possible limb salvage before we went in theater. So we told them, we discussed a lot about what we can do in theater. If the limb is salvageable, we can salvage the limb, and if not salvageable, we can amputate the limb. So when we went in theater, we found the anterior tibial artery and the posterior tibial artery was already torn, and the muscles were very severely crushed, as well also the bone were crushed as well. So we decided to do amputation on that circumstance.
Thank you. Now, one comment before we break for lunch.
Thank you, Dr. Mugisha, for your question. So robotic surgery is just one aspect of artificial intelligence, and there are a lot of barriers to that. One of the biggest mountaineers, like Uluguru, is the cost. I did a quick search just now, and a robotic system cost about $2 million just to get there, and the materials used in each surgery is $1,000 approximately more expensive. Yeah, so these are the add-on costs. So I know you're presenting today on economy of orthopedic care. So I think that's one. So cost is another barrier. Two is the expertise. I think that's a small hill to climb. It's very doable. If we have the systems, we can go and train for them. But also it's the regulatory, like authority. They have to accept it. The patients have to accept it. Of course, the insurance companies, if they're paid by insurance, they have to accept to be able to pay for the extra costs, whether it's for the system, but also the maintenance. Maintenance are very high. So mainly it's the cost and the expertise. So I think that we're not ready for it, but there are a lot of aspects of AI which we are ready for, and we should use.
Thank you very much. We have one presentation that we're moving it to tomorrow. The third presentation on this session. So I'll hand over the mic to Mr. Chairman.
Yes, I think now we'll break for lunch. An announcement about lunch, someone to guide us. As soon as we finish our lunch, we have to get back here because we are way, way back behind schedule. To the water hapa, timely.
Good afternoon. So my name is Dr. Musa. So we have an arrangement for our lunch today. So 30 people will go downstairs on the basement. The rest will go upstairs, floor number 1. The buffet is the same. So you're welcome for lunch. Thank you. So you come there on the registration table, then pick a coupon. Then when you pick a coupon which has written Asao, you go floor number 1 for your lunch. And the other one, Marimba, you go basement. Thank you. You're welcome.